All right. I'm going to introduce our speakers here now. Robin Hussa-Farrell and Matthew Toth. Robin Hussa-Farrell, MFA ERYT, co-founder of Chief Executive Officer of Resiliency and Technologies, who has been working for nearly 2 decades building trauma-informed programs in collaboration with state agencies, educational systems, and interdisciplinary researchers across the United States. The models she has created for over 200 specific experts and peer stories of resilience in documentary film modular content. Robin's work has been published in peer-reviewed medical journals, featured at over 25 national conferences, deployed via resilient school initiatives, and through suicide prevention programs. She lives and works in San Diego with her husband, Tim Farrell, an award-winning documentary filmmaker and co-founder of Resiliency Technologies. Robin holds a master's in fine arts from the University of Virginia and is trained in MBSR at University of Massachusetts, as an experienced yoga teacher and continuing education provider for Yoga Alliance. Matthew Toth is on a mission to help students and families build trust with their schools and communities by providing resources to meet basic safety and mental health needs. Trained in finance and experienced with over 14 years in sales, he is an expert in building relationships that connect solutions to organizations in need. Currently, as the Vice President of Partnerships at Stop It Solutions, Matthew helps to serve over 76,000 schools and organizations to provide a safer place to learn, work, and live through the platform of safety solutions. With that, I'm going to hand it over to Matthew. Thank you, everybody, for being here.
Thank you very much, Sean. So to get started, we really wanted to have you all here to discuss trauma-informed technology and services to improve not only educator emotional well-being, but also for you to be able to help the students and their well-being. So what we're seeing across the nation are that millions of students are hurting themselves and others. And they're doing this through a variety of means. Sometimes it's physical, sometimes it's verbal, and we're seeing an increase in digital activity as well. These take the forms of fighting, substance abuse, eating disorders, harassment, depression. We're seeing cyberbullying become one of the biggest threats to the mental health and well-being of our students out there. And if left unchecked, these behaviors and these things that we're seeing can lead to lethal means, whether that be depression, anxiety, shaming, leading to suicide or suicidal ideation, fighting, bullying, rumors, discrimination, leading to violence, or any of this stuff leading to substance abuse, where we know that students then don't have the best judgment and don't partake in the best behaviors. Next slide. So what we're seeing across the country is nearly 750,000 victims of school violence annually. Now, school violence, we think of guns, we think of fighting, we think of bullying. But as you see here, 17% of teens have considered suicide. Almost 30% have been sexually victimized over their lifetime. And 30% of students have feelings of depression, anxiety, and sadness due to stress. I'd argue that number's probably much higher now after the pandemic and what we've seen coming out of the pandemic. But school violence is more than just our typical fighting these days, right? Or just bullying. All of that stuff is so important to get in front of and to stop. But self-harm, suicidal ideation, and sexually victimized are growing exponentially through the students and through our schools. And next, we'll talk about the mental health trends and the toll of the pandemic.
Okay.
So we've all been through this pandemic, and everybody has gone through this trauma. And students especially, but us adults, we all handle trauma differently, right? Some of us internalize it, and that trauma can turn into stress, anxiety, depression, self-harm, cutting. Other of us handle trauma with outward behaviors, aggression, fighting, bullying. It could lead to weapons threats, school shootings. So next we're seeing 1 out of 5 children and adolescents have experienced a mental health problem throughout their school years. So we have 98 participants on this call right now. If we all think about just one of the students that you come in contact with, right, that you are involved with or a mentor for, think about your own children. 1 out of 5 of these students here. We're talking about 20 to 25 of these students on this call that you're thinking about will experience a mental health problem or crisis during their school years. And it's not just a statistic. Is anybody on the call familiar with the Vessel in New York City? The Vessel is a large beehive-looking staircase in New York City, part of Hudson Yards. It's a weave of staircases that connects a brand new office building, restaurants, shops. It's been a tourist attraction for the last 2.5 years or so that it's been opened. But last July, a 14-year-old boy climbed to the top with his family, and in front of his mother and father, his sister, and his grandmother, the reports say he didn't say a word. He just walked off the top, took his own life. Now, again, one statistic, one story. But from that structure alone, in the first 18 months that it was opened, this was the 4th teenager that took their lives off the top of this building. The pandemic and the state that our students are in right now is severe. And next, of those who did raise their hand and reported a major depressive episode, 60% of the 3.8 million kids who said, I am depressed, I have an issue, they did not receive any treatment. Whether or not communities have the resources or hospitals have the resources, the connections to those resources are what are being severed, especially through the pandemic. We weren't allowed to leave our houses. Students are feeling that. So when they raised their hand and said, I have a problem, they just weren't being connected to the resources. All of you great folks that are on this call are some of those resources. And maybe the help they needed wasn't through a Zoom like this. It was in person and they couldn't get that. So 60% of those weren't able to get treatment. And next, we're going to show you that it's not just nationwide statistics. New Mexico is part of this. According to a recent Mental Health America study, New Mexico ranks 50th out of 51st for the combination of prevalence of mental illness issues and lack of access to care for youth. And suicides account for 29% of the deaths of 15-year-olds through 24-year-olds here in the state. And over 10% of high school students in New Mexico have reported attempting suicide. So again, mental health and wellness hasn't escaped the US, and it certainly, unfortunately, hasn't escaped New Mexico. Next, we'll see doubled the number of children aged 6 through 12 that visited children's hospitals for suicidal thoughts or self-harm since 2016. That's doubled. And remember, these are just the children who have visited children's hospitals, right? Not that 60% that didn't receive any treatment. Now, from 2016 till now, it's a big gap. But the pandemic had a significant effect on this number. Take Clark County, Nevada. It's the 5th largest school district in the country. From school year 2019 to school year 2020, it doubled the number of suicides that it had. Not just suicidal thoughts or self-harm, but doubled the number of suicides in one school year, which prompted their administration to bring students back into school during the pandemic much quicker than anticipated or that they were ready to do. But they had to make decisions like that because they saw the number of suicides double in the 5th largest school district. And next, it's not just large school districts that are having these problems. April of 2020, so just a month after the pandemic was really declared and we all went home, a very small high school in Colorado lost 2 students within 9 days to suicide. After investigation, the reasons for both of their deaths were due to isolation, having severed ties to school, friends, sports, and those trusted adults and mentors that they had at school. And it just doesn't stop there. Stop it itself. We saw life-threatening incidents, meaning an immediate threat to oneself or another, skyrocket during the pandemic. Pre-pandemic, life-threatening incidents made up 18% of our cases. But during the pandemic, life-threatening incidents made up 40% of our incidents. They were using our platform to cry out for help. Unfortunately, with the new year, 2022, things haven't changed for the better. Valentine's Day marked the 4th anniversary of the nation's deadliest high school shooting down in Parkland. And this 21-22 school year is on track to be the most violent in recent years. Despite all the efforts of the student-led gun control movement ignited there in Parkland, new studies are showing that there's already been 136 instances of gun violence on school grounds. And that was just the first half of this school year. That's a figure that's nearly 4 times the previous average for that period. The turn of the new year did not change this. In just the 2-week period leading up to that anniversary on Valentine's Day, so just the first 2 weeks of February, the news stories were this. Friday, a 19-year-old former student was shot and killed after a high school basketball game in Wisconsin. That coming Monday, there was a shooting outside of a high school in Las Vegas that left 3 teens hospitalized. The very next day, on Tuesday, 5 teenage girls were shot and injured outside of a high school in Milwaukee. That same day, a student was killed and another shot outside an education center in Minneapolis. Later on that week, a bus driver driving a busload of elementary school students was shot. All in this 2-week period before the anniversary of the most deadliest high school shooting. The problems that predated the pandemic, such as inequality and inadequate resources, have grown even worse because of COVID-19. They've introduced new challenges like creating stress. So much stress that nearly half the teachers say they want to quit or retire early, according to the National Education Association. So is anybody safe? Next, I'll show you the disparity between girls and boys and how the pandemic has affected them. Nobody's safe. Girls and boys are feeling the effects of the pandemic through anxiety, depression, sleep issues, withdrawing from their family, and showing aggressive behavior. And next, there is no place that's safe. It could be on private social media, things going on at home. But what you're seeing here, this is data captured from a network and device surveillance company. This is all information that lives on a school's network. This is not private device. The numbers here show the difference between the first 3 months of school year 19 and 20 to the first 3 months of school year 2021, pre-pandemic, post-pandemic. Well, pandemic's not really over, but during pandemic. They saw an overall increase of 66% of incidents. They saw an increase 83% more words used around suicide and self-harm, a 63% increase in violence towards others, 135% increase in nudity and sexual content. Yes, this is on the school's network. And almost a 60% increase in drugs and alcohol. These are all keywords on the school's network that were caught in emails, in journals, on Word documents, or in GChat. But the most alarming statistic here is not on the screen. In that first section, the first 3 months of 19 and 20, just 4% of these incidents were from elementary school. In that second group, 13% was from elementary school. So these things are happening at a younger and younger age. As students were at home with older siblings, seeing and hearing what they're doing on a daily basis, having access to internet-enabled devices 24/7, whether it be phones, school-issued devices. They are seeing and being exposed to these things, and it's changing their behavior. So a lot of the things we talk about seem like it's a high school issue or seem like it's a middle school issue, but what we're seeing more and more is that it's an all kids issue, all the way down to kindergarten and pre-K. But if all these issues are happening, next we'll see that somebody witnessed these behaviors, right? Somebody saw that social media post about getting darker and darker and eventually wanting to take their lives. Or somebody saw or heard one of their friends or another student talking about how depressed they are and they're going to end it all, or they're going to bring in a gun and really show everybody who's boss. But the problem here is your students and your staff members are seeing these things unfold, but did nothing to intervene. They chose to be a bystander instead of an upstander. And here's how we know that's happening. Next, 4 out of 5 teens who have attempted suicide have given clear signals of their intentions to others. They've raised their hands. They've cried out for help. They've either posted it on social media or they've asked somebody. They said, this is what we're going to do. And next, 85% of bullying episodes, at least one peer was present, right? The students or staff members are seeing this stuff. And 2 or more folks are present in 50% of the cases. But again, nothing was done. They either weren't trained on how to handle it. What does really bullying look like? Should I report this? Should I tell somebody? And next, 3 out of 4 spoke with others before they carried out a school attack. They either said, hey, I feel like this. Come join me. They're recruiting people for their team. Don't you feel like this? Come join me. Or they said, where can I get a weapon? I don't know how to do this. Or maybe they were Google searching how to make a bomb or how to make a weapon, or the school plans, or when is the security guard off. They've given signs. They've spoken with others. And next, 80% of mass shootings are preventable due to the presence of early warning threat indicators. As I just mentioned, they Googled something, they looked something up, they posted it on social media. I was just speaking with another district the other day, and they said one of their students started to dress like, started to speak like, and started to model their behavior after the Parkland shooter. They started to idolize this person because of the depressive state that they were in. And again, it was starting to show itself on social media. It was starting to show itself in the classroom. It was starting to show itself to the friend group. Luckily there, they had some upstanders that started to say something so that they could take action before something happened. But in 80% of the cases, and this is according to the US Secret Service, their threat assessment center, that after they investigate, they see that 80% of mass shootings are preventable due to these early warning threat indicators. But the idea is there enough training out there to teach students and staff members how to identify these behaviors? How do we get them help? And it's not just the students. Next, I want to play a little game. I'm going to read some of these quotes to you, and I want you to guess what state they're from. This is not sustainable. A general sense of helplessness and fear has permeated our school. These students are in crisis. Schools are in survival mode. School staff have been bitten, spitten on, kicked, punched, urinated on, hit by thrown objects, etc. This is the most difficult period in public education in my 23 years. Anybody take a guess on what state these quotes are from? See one popping up, New Mexico. A couple from New Mexico. Well, this is a presentation in New Mexico, but no, it is the most terrifying state of Vermont. Right? And if it's happening in Vermont, it's happening everywhere. Schools are in survival mode. Staff members, social workers, nurses, counselors, psychologists. It is probably the most difficult period of public education in all of your careers, all of your lifetimes. And next, a great quote from an article that said principals across the state are saying that their teachers are more stressed than they've ever been and that students are more dysregulated. The person in that quote doesn't know how right they are, right? This stuff is happening everywhere. But the problem, and a lot about what Robin's going to speak about in just a moment, are that, yes, the students are more dysregulated, but so are the staff, right? And next, a regulated, calm adult can regulate a dysregulated, anxious child, but a dysregulated adult can never calm a dysregulated child. And if Sean threw up another poll of how many folks in this webinar right now would classify themselves as dysregulated, stressed out, anxious, it'd probably be the highest percent yes of any poll that we take here. It is one of the toughest times in public education. You are stressed out, overworked, plates are full. And the biggest problem here is that if we as adults are dysregulated, there's no way we can help to regulate a dysregulated student, almost making it worse, almost re-traumatizing them. If they come in from home where there's abuse, or where there's depression, or where there's anxiety. And if the adults are feeling more stressed and anxious than ever, students who are acting out or disassociating are in fact having a normal brain response to the adult's current state, right? Our emotions, our reactions are contagious. I know if I'm stressed out, I'm stressing my son out. I know if I'm anxious, my sons get anxious. And your students feel the same thing. So how can you support your staff? So next, we'll talk about building on the foundations that you've already established in your support system. Now is not the time to try to reinvent the wheel. Now is the time to double down on your EAP platforms, on your systems, your programs, and your services that you already have. Try not to add too much to them because you'll be overwhelming students, staff, and even yourself. But instead, try to be more focused on the message around these programs that already exist by taking care of you before taking care of others, right? When you're on an airplane, please put your mask on before assisting others. And unless requested, try not to push anything too new, right? We need to build a platform and give people opportunities and space to learn about trauma, become trauma-informed first, allow them and educate them to think about their own triggers and reactions while recognizing that their reactions, no matter what they are totally normal. Sometimes those reactions may not feel appropriate, but in fact, they are normal. And once you identify them, now we can do something about them. Now they can be reeled in. But if somebody is not recognizing those reactions and those emotions, naming them, whatever way that you want to go about that, you can't make a change there. And right now, there's so much funding out there, right, to accelerate learning. We lost so much time. But if you tell somebody they need to speed up right now, they're going to look at you like you're crazy because their plates are overflowing. There's a line out all of your doors. The caseload is so big right now. And when trying to look at something new or changing, you need to consider investments and actions to mitigate the effects and cost of trauma, stress, anxiety, violence, suicide. You need to help your schools recognize that this foundation of trauma-informed must be built before they see the results of learning acceleration, achievement. We always talk about being efficient and effective, but none of this stuff will be realized if we don't understand how we're reacting to the trauma and the stress and the anxiety that we're all in right now. All of these will go for naught. And when adults understand the effects of the trauma, they can better understand the students, families, and staff who experience it and more effectively address the completely predictable behaviors that stem from trauma when they arise. So if we're trained in identifying these, we can have a better plan to attack it. We can have a better plan to mitigate it. And there is evidence that a trauma-informed approach to supporting staff increases retention, addressing the costly issue of workforce turnover and scarcity in first responder, child welfare, social workers, educational systems. Again, if we did a poll and said, who has open recs in the social worker or the counselor department, or who could just use a second hand, another one of yourselves, right, to tackle this caseload? I'm sure most of you would say yes. But how do we keep these folks? We need to have that trauma-informed approach so that they feel comfortable, not stressed, not anxious, so that they can focus their energy on the students that they're there to protect and serve. And all of this trauma-informed approach also helps to reduce reports of compassion fatigue. Compassion fatigue is when you no longer care if somebody's suffering. I was on a call the other day with a social worker, not in New Mexico. And I know this social worker cares for their students and the families that they serve. But we were talking about, bringing on a new service. And they basically said, I'm contracted from 7 a.m. to 3 p.m. I don't care what happens to the students afterwards. And I know they didn't mean it like that. I know they meant, here's my job. I'm so stressed out. I have a family. I have other things I need to do after work as well. I can't be on call 24/7. We're trying to learn a new service or whatever you're asking me to do. And I know she was just really overwhelmed. It wasn't how she actually feels, but she was so burdened with everything that was going on that it came out as compassion fatigue. She no longer cared if somebody was suffering. It didn't matter. She had her tasks. She was doing those tasks. And she was in that alarm state where she could only think of the now, right? What's next? What's the next email? What's the next thing on the top of the plate? Not the future. You also need to advocate for yourselves and for the decision makers in your districts to apply a trauma-informed lens when outlining requirements to obtain funding or to add new programs and services. You want to make sure that they focus on providing tools and services to support mental health balance, restore calm, and promote well-being. Now, how do you do this? You can start with applying SAMHSA's 4 R's of a trauma-informed approach, which we'll go over next. The 4 R's, a program, organization, community, or system that is trauma-informed, realizes the widespread impact of trauma and understands potential paths for recovery, recognizes the signs and symptoms of trauma, responds by fully integrating knowledge about trauma into policies, procedures, practices, actively seeks to resist re-traumatization. So how do you do this? How do you follow these things? How do you understand if you're actively resisting re-traumatization or responding by integrating knowledge into policies and procedures? Well, next we'll start to talk about that. So what else can we do? This pandemic has been a traumatic, fearful event, which can have lasting adverse effects on mental, physical, social, emotional, and spiritual well-being. We're seeing it. That is coming out more and more. I shared some with you, and every day it seems like we're getting more out of this. Just a quick example, we're seeing trauma in the uptick of sleep disorders. I know I'm cranky if I don't get my sleep. I'm sure the teachers, I'm sure yourselves, I'm sure janitors, admins. If I'm making a new policy and I have a sleep disorder and I haven't gotten a week of good sleep, that policy may not get my full attention. That policy may not allow me to think in a well-balanced, calm way when I'm making that policy. The words might be a little harsher than normal. The language, the meaning, the underlying meaning may take a different form. We're seeing trauma in undesired weight gain. I can definitely attest to that. Depression, burnout, substance misuse. If a staff member is very burned out and they're anxious and depressed and they're turning to self-medication, are they going to use the EAP program that you have in place? Is a teacher going to raise their hand and say, yes, I have a drinking problem? Some may, most probably won't. Do they have other ways to get resources and help and identify that the way you're handling this is an okay or a normal reaction, but it's time to get help? Practical steps can be taken to recognize and respond to trauma and provide supports to those who have endured mild or intense anxiety, fear, isolation, and depression. Taking steps to gain control over one's circumstance may assist those experiencing trauma to alleviate some of the effects they've experienced. The far-reaching impact of collective exposure to chronic stressors and trauma necessitates approaches that equip as many people as possible to recognize and respond to trauma in themselves and others. All of the folks on this call are usually the ones in the district everybody points to when you need to be trained or equipped to recognize and respond to trauma. You need to be advisors to your district and push this out that all administrators and all teachers should be trained to recognize and respond to trauma. There are so many funds available out there, especially to schools right now. But in most cases, even the decision maker is not in the best state to make a decision, or may not even want to make that decision, right? They may be so overwhelmed that, yes, I have $1 million coming in to spend on this area. I can't even think about it, right? Something that would help staff members, administrators, students, teachers. So if you can ever position yourself as a guide, or just walk them through a little bit of a training, or brain basics, or resiliency, or some of the things that Robin's about to teach you, you can help calm them down. You can help realize that it's okay, and they can make a clear, informed, trauma-informed decision. Even us, Stop It If you know of us, we've always been a school safety company, and even we have had to pivot to be a trauma-first company. So next, some action items. What can we do? What can educators, what can districts, what can staff members do? Create positive, safe, and affirming school environments. Do everything you can to provide a safe environment. Expand social emotional learning programs and other evidence-based approaches that promote healthy development. We have some. What Robin's going to go through, definitely evidence-based approaches. Learn how to recognize signs of changes in mental and physical health among students, including trauma and behavior changes. Provide a continuum of support around health needs, mental health, trauma-informed care. Expand the school-based mental health workforce. We talked about hiring. We talked about the Great Resignation and how if folks are stressed and anxious, they will quit, they'll turn over. How can we expand if we aren't a trauma-informed first district? Support the mental health and trauma awareness of all school personnel. So this is great, but how do we do this? Well, there's things out there like e-therapy, right? If you can't expand in person, get a helping hand. E-therapy can take a few of the cases, do some of those initial evaluations, and send you off with an action plan moving forward. If it could just save you a little bit of time. Anonymous reporting, one of the platforms that Stop It stands on. You can get in front of these behavior changes. Having your students that we just saw, where the eyes and the ears, right? They see things happening, but don't feel comfortable saying anything. Give them an anonymous way to report what they're seeing, hearing, and feeling, whether that be about themselves or one of their friends. Could be what they're seeing on a teacher. Do you have access, or do you give access to your community for all the national and local resources available? Do you have a concise resource section that they can go to anonymously so they don't have to perform their poverty if they need food or they need shelter, they need clothing? Do they have an easy way to access all of these national hotlines, the New Mexico hotlines that are out there? Invest in behavioral threat assessment training. Once a student has been identified as a potential threat to themselves or to another, have you enacted a threat assessment training program as well as a case guide system? So with all the turnover that's happening, that threat assessment program can be step by step, the same way for every student threat every single time. And next, this is one of the reasons that we partner with an education service agency in New Mexico, Central Region Educational Cooperative. We have a federal grant that we're servicing along with 11 others across the state, across the nation. We're currently in over 21 school districts, and we help provide anonymous reporting, crisis text line, crisis counselors, SEL and wellness training centers. All of this as part of a federal grant that is at no cost to your districts through June 30th of 2023. And we always look for continuation funding. If anything piques your interest there, please let us know after the call and we can help give you more information there. So next, what can you bring back to your administration from this call? If you can, you want to protect and prioritize students with higher needs. Again, use things like e-therapy to maybe take care of somebody without special needs. Also prioritize and protect those with higher risk of mental health challenges. Provide access to comprehensive, affordable, and age-appropriate mental health care for all employees and their families and their children. Implement policies that address underlying drivers of employee mental health challenges, including both home and workplace stressors. Create a workplace culture that affirms the importance of mental health and well-being of all employees and their family. And if needed, take assessments. Regularly assess employees' sense of well-being within the workplace. Again, are we getting enough sleep? Are we just overworked? Are we so anxious and depressed because of other things that are going on, we're going to start to make bad decisions. We're going to turn to self-medication. We're not going to be as focused. We're going to transfer those emotions onto our students, right? That then again, start to snowball and affect others. So how can you do this? Mental health assessments, whether they be suicide assessments, well-being assessments for both students and staff. Continue on with your employee assistance programs. See if there's little tweaks that can be made in either policies, add-on services, and so on. And most importantly, SEL and wellness, compliance, safety, and trauma-informed care training. You want to make sure that these are all in the system to prevent the re-traumatization of students and staff when they walk through your doors each day. And with that, I'm going to turn it over to Robin to continue on more about trauma-informed care training.
Thank you, Matthew. Hi, everybody. I'm Robin. It is so great to be here. Such an honor to be here with all of you. I just kind of want to check in here with you all about halfway through this presentation and just sort of see, actually, other than us going through our learning objectives and sort of just kind of going through our presentation from this point forward, given everything that Matthew has shared and the great research and data that he's provided, I'm curious to learn from you guys, if you could put into the chat, what brings you here today, other than your CEs or your CEUs? Why are you here today? What are you looking to gain out of a workshop around trauma-informed best practices to improve both educator, but other community resilience? So share with us in the chat. And that's important to me because I've been asking these questions for now going on 20 years, especially among the school-based mental health professionals, educators, staff, administrators. And we learn a lot just by listening, right? And so I really want to make sure that we're giving you everything that you're seeking today. So it's really an honor and privilege to be invited to get to be here today. My background, just to kind of go high level for you all a little bit. I am a health educator, pretty straight up and down. My area of expertise and research began in disordered eating prevention and comorbidities. I worked alongside over 200 national researchers and experts to design evidence-based interventions for the school setting. And a lot of that work is available, and I've shared with the team here today a handout so that you all have access to a lot of the things that we're talking about today. So this might enable you to feel free, a little more freed up during this session today. So I'm looking over the chat. I just want to kind of pause here. So knowledge and awareness, tools. What can we get out the door right away? So my promise to you guys, Matthew and I think both can promise this. We have so many tools and resources, and I know this is a very overwhelming topic. I know it's a very overwhelming time for you all, especially being in the front line, seeing things that none of us ever imagined we'd be seeing. So I want to sort of promise that you're going to have a toolkit by the end of this session today. So that's one takeaway for you. One thing I'd like to say, and next slide, please. As we're looking over the objectives, my background in terms of working in trauma-informed schools, I've had the great privilege of working for about 8 years in the state of South Carolina on a resilient schools initiative. I was the mindfulness and MBSR instructor and sort of designed the interventions that have been deployed for the educators at the classroom level. So my experience is going to be kind of focusing a little bit on that data. And then secondarily, I also direct a suicide prevention task force for the upstate of South Carolina. I want to share that with you because it's another tool in the toolkit, and we are seeing some very exciting data there. So it's from this data that I'm going to be driving the conversation, again, to give you more tools in your toolkit, but also some best practice strategies. Next slide, please. 20 years ago, I saw there was a problem in K-12 schools, like all of you guys who are the experts in the field. We saw that regarding mental health. All of you are probably going to be nodding a lot during this section. You're going to be like, yep, been there, done that, have seen that. Students, of course, were dealing with a level of mental health stress that few seemed aware of, and few structures were in place to actually deal with it. In fact, in 1999, the US Surgeon General declared suicide a public health crisis. So that's back in 1999, folks. 1999, we already declared that a crisis, and look where we are today. So recently, thankfully, the current US Surgeon General has issued a national strategy for suicide prevention. I've included that in your toolkit in the handout resources for this session. What I started doing way back 25 years ago was connecting researchers and their best practices, especially those in child and adolescent mental health and psychology, psychiatry, right to the schools, and really through professional development of folks like you, school nurses, the social workers, the behavioral, the CRTs, MTSS team leads, been there, done that. Together, we built training programs based on their expertise and the needs we were seeing in the trenches. So now those programs have reached over 1 million students, staff, and professionals across 15 states. And so I'm here today to share some of that data, but really some case study where the rubber meets the road for you all, so we can take all of this data, all of the prevalence that we are seeing, and actually apply that. Next slide, please. So some of the slides I'm going to show you right now are me in the trenches doing these trainings in collaboration with these researchers. As a health educator, I was really passionate first and foremost about ensuring that the PD wasn't just your typical sort of drive-by PD and then you never hear from us again. It was really important. I come from a family of educators and folks in research. So it was really important for us to make sure that the type of PD we were serving up in mental health especially was the highest quality possible. So I worked in New York City in the entertainment world for many years, as did my husband. And we worked together to develop documentary style film training. So the reason we are able to engage audiences is because we've traveled the country almost 20 years filming the national thought leaders and researchers. And I'll share more about that. After each of the hundreds of trainings that we did, we were able to conduct post-program surveys, and we continuously then improved our offering, the tools that we offered, the handouts, resources, and providers that we brought into the school settings back in those days. Next slide. I was passionate in making sure that we had to have hundreds of those trainings that sought to really move the needle in the right direction. We were able to see over 33 school districts across 14 different states access to not only the evidence-based intervention that would happen at the school level, but what do we do now? It's so great to hear about all this prevalence data, as all of you guys have just said in the chat, but it's like, now what? Okay, the rubber meets the road. What can we do tomorrow when I've got my little third grader who is struggling with adversity? We know that those adverse childhood experiences are on the rise given COVID. And so the question we were seeking to answer was, now what? We developed, next slide, please, over 50,000 surveys that we captured, and those enabled us to actually serve up the information that folks were asking for. So out of those 50,000 surveys from all of these trainings across all these different states, training folks like you, training the educators, training parents, and training the students, we learned from them what they wanted to know about mental health and what they already knew about mental health. And remind you, this is 20 years ago when we weren't even beginning to talk about mental health, as you guys are probably nodding your heads. So when we learn and we ask and we engage our audiences to share their expertise, we are able to do better, to do more. And so we started serving up exactly what they asked for. Next slide, please. And what we learned was simply that frankly. These are the commonly asked questions that you're seeing on the screen here. You're seeing that the 50 components, we distilled down those commonly asked questions, and we categorize them into 4 primary areas. Areas of risk that we are seeing most in schools. And unfortunately, and all of you can relate to this, and probably have an additional 50 components, that we are really system-wide. This is not just our school systems, right? Our entire communities weren't talking about mental health. And suddenly COVID has hit. And now we are, and it was the paradigm shift that we needed to impact us in the right direction. However, the 50 components putting folks at risk, and I will get into those with you if we have time at the end of this presentation today. We categorize them into kind of 4 categories. And those were around the area of knowledge and learning. So we can learn more, we can do better. It also was around that system overwhelm. So how many of you on this call are tired of hearing MTSS, PBIS, ISF, alphabet soup of our framework sort of jargon, that it's like those are fantastic and obviously they're best practice. But how do we actually, again, tomorrow, when my 3rd grader who's struggling in the classroom setting, how do we actually bring that into a real use case? And of course, today we're going to be sharing some of that case study as well with you all. So you can see on the screen here, mental health stigma. We talk about this a lot, but that stigma goes across all the different tiers of influence within the school setting. The stigma at the administration level, the shame and stigmatization, certainly around the educators themselves, pose barriers for them to engage in mental health content or mental health literacy content. Shame and stigma from parents. I actually had a parent say to me that they forbid us to teach about disordered eating and anxiety, anorexia and comorbidities within the school setting because folks are paralyzed, and there are cultural barriers, right, to those shame and stigmatization layers. So we could all talk together for 7 weeks just about that first bullet point. So it was really essential that we kind of developed a formula that would address that shame and stigmatization using evidence-based best practices. And I'll share more about how we did that. Health illiteracy, mental health illiteracy, critical problem. If you don't know what a mental health disorder or the mental disorder gamut, it's really hard for us to do better. And that's us as a people, as a community. And I'm sure many of you bang your heads against a wall saying, gosh, if I could say to every single one of my kiddos in the school systems, basic protective factors to help them manage and get ahead with healthy coping skills and building resilience, wouldn't it be fabulous to just get that out the door to those students early on? But again, there are just so many systems level barriers to that engagement. Lacking high quality and engaging content. We all have been to the sort of trainings that are less than engaging, to say the least. And I don't know why that happens in our field, especially in the field of mental health, but it is a common trend. And I empathize greatly with all of us who've been a part of some of those sessions. So it was really critical that we got ahead of that and tried to find engaging ways to build content that really sparked our audience. Lack of connectedness. So if you follow any of the suicide prevention best practices from the Zero Suicide Framework and others, you know that we need to stay interconnected, and nothing could be more true during COVID when we're isolated and we're sort of in these silos. So how we bring people out of the silos and stay connected was another great barrier. So again, at the end of this session, if there's time, I will dive more deeply into some of these 50 components, putting your district at risk. To say the least, I think for the purpose of today's sharing and for this case study, I'm going to focus on educator resilience and the educators themselves. Matthew addressed the compassion fatigue, the burnout. What we found was on average 10% of our educators actually after a mental health training and or a mental health literacy intervention in the school system, we found 10% of those educators would come forward to seek care for their own well-being. And again, this was 20 years ago. So nothing could be more true now than what all of us are seeing in the trenches. So I'm pulling out a case study today for educator emotional wellness, because that's an exciting piece of data where we're seeing in the world of prevention that we're moving the needle. The frameworks that we built and that I'll share with you today cover all those tiers of supports. So not just the educator level, the students themselves, the parents, and professional development for school clinicians. Next slide, please. So we built Sharpen, of course, to address the challenges that that I've been talking about naturally. What I really wished for, and I did this selfishly, so I was working as a nonprofit. My work and my research was funded particularly by children, families who lost their children to suicide, families who lost their children to mental disorders, substance use disorders, and eating disorders. And so all of us were fed up like you guys are, and you're seeing this and you're nodding your heads. So selfishly and passionately, I wanted to build a technology platform that would try to fill those gaps that I saw for 20 years. And so that's what we tried to achieve with Sharpen. We named it something that is a neutral name like Sharpen because of that stigma. But through technology, we offer all the comprehensive supports that fill some of those risk factors, and especially those that Matthew was talking about. So out of the box, Sharpen provides access to documentary style film content. We have over 600 educational modules that are CBT focused, so they can be served as a CBT intervention, SEL focused. They enhance shared protective factors for resilience, and I'll go into our logic model a little bit more. But I also wanted to make sure that if we were deploying content or an intervention at the student level in the classroom setting, we needed to have appropriate content that would help educate the parent and the educator. So each of those tiers of support receiving age-appropriate evidence-based intervention was the ideal. So it took us a very, very long time and multiple research collaborations to develop what is really under the hood of Sharpen, which is its content library. We've been able to show through multiple research studies that the system of content, the way in which we deploy content, improves mental health literacy, which I'll get into. It improves safety in managing mental illness in schools, and improves competence and confidence in actually assisting a student. So we saw that at the educator level. Next slide, please. Our impact is those stigmatization numbers that I mentioned earlier. You guys know when you try to hold a training for your parents in your district and you're like, hey, we're going to do a depression training today. And literally everyone runs out the other door and they, go in an opposite direction. And you're probably like, yep, really hard to get those families or educators or others to attend. Well, I've been there, done that. And what we found is using peer stories of resilience in a strength-based model, we were able to engage people very deeply into these subject matters, very compassionately. When ideally an individual sees people who look like them, talk like them, walk like them in terms of cultural and socioeconomics, we saw an improvement by over 86% with mental health content and treatment. Which was astounding, those numbers. We saw an improvement of over 90% of the educators' mental health literacy. I'm going to share more of that data and that use case today. And the decreasing of mental health stigma. In fact, we just ended a longitudinal study under IRB with a medical school. And many of you will be able to identify with this, especially my nurses who are out there. The burden we still face in 2022 among medical professionals, that within medical school, within our health systems, why do we still have so much shame and stigma around mental health? It is unbelievable. we saw a decrease in that mental health stigma by 90% using our strategies, our framework, and our content. Next slide, please. So I'm sharing all of this because I think it's super important for you to know like the why and the how. And I want to also give you a little bit of public health best practice, though this may be second nature to you all. So what we have on this slide is really looking at the primary, secondary, and tertiary prevention supports that are within the district. For us and for the epidemiologists we follow, primary prevention is like the dream, right? We hope that no child from this point forward would ever develop onset of a mental disorder. Wouldn't that be fabulous? So we can keep trying and working toward that goal, but we know we need to have those secondary and tertiary prevention supports. Dr. Nadine Burke-Harris, whom we all probably love and celebrate, she released that roadmap to resilience back in 2020, outlining the importance of a public health approach that focuses on primary prevention efforts, those targeting healthy individuals and aiming to prevent harmful exposures from ever occurring. So in the example of ACEs and toxic stress, primary prevention would look like something that we designed to actually prevent and reduce the likelihood of ACEs or other risk factors from ever happening. So those would include things like training and education, teaching the educators, the families, mindfulness-based interventions at the classroom level, as we have seen successfully implemented for 5 years throughout South Carolina Resilient Schools initiatives. Secondary prevention includes screening and early identification to locate those who may be struggling. I've included an exciting recent study from one of our partners who has a validated evidence-based screening tool for children and adolescents. It's called Heads Up Checkup, and I'm so excited about it. It kind of has a gaming feel to it, but it's very cutting edge and has a beautiful intelligence. That's going to be in the toolkit provided today. But if we're not screening, we're actually going to miss those kiddos and they're going to be falling through the cracks. A lot of us are screening currently for that social emotional cohort, but we may not be screening, as Matthew referenced, for suicide ideation, those higher risk factors, threat assessment, and/or mental disorders. Tertiary prevention, as you all well know, being in the roles you serve, that's when we need to provide some support, whether it's in the school system or outside, for the students and educators who might be struggling. So they need access to care, free and reduced sliding scale services. We also need to be connecting them to care in between those clinical visits or sessions. So that's our tertiary prevention layer. So we built Sharpen to cover all three of these layers with a strict focus on the primary prevention. So our service is really being used kind of across those three. In terms of the tertiary, it's a little more of a CBT, DBT intervention to support individuals in between clinical visits. And then certainly in primary prevention as a professional development or mental health literacy training resource toolkit. Next slide, please. How in the world of public health and how for you guys do we even begin to measure improving resilience or improving a trauma-informed framework within an entire system? We do that through protective factors. So in the world of public health, we measure the improvement or reduction of a protective factor, seeing the ways we are decreasing risk and improving protection. And so I've put here, this is actually the framework that Sharpen is built under. You see the symbol for Sharpen in the center of that flow chart. Our focus, and again, based on my research, suicide prevention being at the top, trauma and resilience has got to be one of the anchors, along with the mental disorder gamut. So where all three of the protective factors for those three categories come together, that's what you will find within Sharpen in terms of its content and its approach. Following the 2006 research of epidemiologist Dr. Newmark Steiner at University of Minnesota, we want to find the shared protective factors that enhance resiliency and decrease risk. So in the handouts, you will see that a little more deep dive regarding this and the protective factor framework. For today, we are going to focus actually on mental health literacy and suicide prevention. So I'm going to highlight those a bit more in especially today's case study. Next slide, please. In October of 2021, the U.S. Department of Ed issued new guidance on supporting child and student social, emotional, and mental health. Sharpen fulfills all 7 of those guidelines. I've listed them here, some of them. One of them in particular is highlighting the importance of improving mental health literacy and reducing stigma. So as you can see from this list, it does include a comprehensive strategy. We've got to be working under that PBIS framework in order to get our MTSS team leads to be able to deploy this to all tiers of students. So it's a huge undertaking for all of you guys to be in the trenches having to navigate this. According to national thought leaders in school mental health, like Dr. Mark Wiest and Susan Barrett at PBIS, I interviewed both of them. They're also on my advisory team. A major component of PBIS includes improving mental health literacy along with those social emotional skills. So we don't want to think about only social emotional learning at this stage. Mental health literacy has got to come in alongside, and I will share a little bit more about those best practices. After 20 years of leading mental health literacy initiatives in schools, there is the right way to do it and frankly, the wrong way where you're increasing risk. So you want to obviously be sure that you're following those frameworks. So when you're understanding your own mental health and well-being, you're understanding how those mental disorders can be treated. And the earlier we seek treatment, of course, the better our outcomes, but also learning the evidence-based best practice treatment providers within the community in sort of a shame and stigma-free environment. So that's not always easy to do, especially with children and adolescents. So I'm going to share a little more about that. Next slide. We can't really talk about, next slide, please. Very good, thank you. We can't really talk about mental health literacy without suicide prevention. So I want to address this. I also want to just take a moment to know that we're sort of rattling off all of these strategies and frameworks. You guys are the ones who are there. I am a certified postvention trainer for an incredible program called Connect Postvention. It's a NAMI, New Hampshire evidence-based intervention. If you don't know about it, guess where you're going to get access to it at the end of this session in your handouts. So I decided to become trained through the Office of Suicide Prevention in our state, mainly because I was seeing too much suffering. And I just thought that this solution in terms of postvention really helped us get the conversation started using evidence-based strategies. So we know that you all are seeing loss. We know that you are experiencing tragic loss. There is no shame and stigma at all in this safe space to have this conversation. What we do know is that there are practices that are current, that are informed by recent research that we can be following. We also know that child suicides have been on the rise since COVID. So we know all of that adversity is around us. So part of my case study today is going to be how a community in South Carolina tackled suicide prevention. As the director of the Suicide Prevention Task Force in the upstate of South Carolina, I've had the great fortune to be trained by national suicidologists, including Dr. Alex Caridi. If you have never attended one of Dr. Caridi's workshops, I highly encourage it. She is now based at the Suicide Prevention Resource Center and also at the American Foundation for Suicide Prevention. And again, you're going to get access to her through the handouts at this session. So pictured here in this photo is Dr. Caridi leading a workshop. We held a symposium back in 2017 because we were listening to what educators needed. We held and brought in national suicidologists to conduct some training for both the educators but school professionals across the state of South Carolina. After the symposium, we learned suicide prevention training was the top requested among the school professionals. And I bet if we surveyed you guys today, that may be of interest and certainly top of mind. As a result, in 2017, we launched a suicide prevention task force in our county with licensed clinicians only at the beginning to sort of have that safe space along with the school psych team leads. The case study that I'm going to share with you today is going to feature one of my favorite humans, Colin Bauer, who was the school social worker in one of the districts. We actually met through the suicide prevention task force. The task force enabled us to have a safe space to discuss increased training and screening and like what all these frameworks and how do we get our arms around kind of framework overwhelm at the district level. But how do we do this efficiently tomorrow to support those kids that we're always serving? So the safe space of the task force enabled us to really look at training first and foremost. So we trained hundreds of professionals in evidence-based models using a framework. It's called Zero Suicide, if you haven't familiarized with it previously. And we also utilize some of the best practice across every sort of culture is the Living Works curriculum. So some of you may have heard of Assist, some of their other models. Again, you're going to get links to all of this at the end of the session. Another fabulous model is Sources of Strength. So if you've done that already within your community, you know it's just a fantastic resource. I have a lot of those links again in the handout section, but I want to emphasize that. So addressing that shame and stigma, right? So the more we leaned into a task force model, what I did in terms of setting up that task force was ensuring that we always had professional development and training at every quarterly meeting. I promised my school professionals that we would be in a safe space always within the walls, either virtually or in real. And then we started inviting interagency partners, such as our emergency departments. And some of you are going to be nodding your heads going, yep. So what you all may know is that the more we're sending our kiddos to emergency departments, particularly if they don't have psych support in place, and certainly child and adolescent psychiatrists are on such a colossal shortage right now. We're seeing the system overwhelm in those emergency departments. And I bet you guys are seeing that same pain point. Well, indeed, we saw that in our community. And so we had the head of the emergency department, behavioral health. She came in and she gave a presentation. And lo and behold, in our case study, we found back in 2017, 2018, that our local Department of Mental Health had embedded mental health professionals both in the schools and in the emergency departments. We figured out a way through that partnership with the Department of Mental Health to empower those social workers and those clinicians that were in those institutions to be able to kind of provide that interconnective support for the children and the families that we were serving in those two systems. It's not perfect by any means now, but just providing a safe space to have those thought leaders come to the table and just brainstorm showed great impact in our community. We had multiple trainings by our school, those emergency room specialists, including the nurses, especially the nurses, because they're the ones seeing it in the front lines on the floor room staff. And we did see a somewhat of a decrease in those children being sent to the emergency department. So in terms of care, that is one great example of where a task force assisted us in terms of moving the needle. So through that coalition building, we certainly addressed stigma. We had just openly talked about all of our fears and the trauma regarding the suicide loss in our county. We provided multiple prevention and postvention workshops and support for our district leaders, for our school-based clinicians and professionals, and then also for the educators themselves. All of us on the front line needing that postvention support. It's so critical. So I recommend for you all that you would dive deeply into the resources you have, which appear to be fairly robust. I did a little bit of research in New Mexico. Your state suicide prevention coordinator is Dr. Doherty, and I've listed her name and contact information at the Office of Injury Prevention, Epidemiology and Response in your Department of Health. You may have already connected with her. The way we utilize that in the state of South Carolina, we also had a head officer at our state level. And I just sort of requested training after training after training, and we were able to triangulate that and provide some support and resources. So next slide, please. What we're talking about, and anytime we're talking about prevention, best practices, this will be another check the box for you all. We want to make sure that we're following socioecological model. So if the circle that is purple there, that individual, that third grader who we are seeking to help reduce suicide ideation, reduce her experiences with adverse childhood trauma and adversity that's going on around us, we need to make sure that all of the circles of influence around her are properly trained and supported. So nothing could be more true than when we're talking about suicide prevention. And so that, in general, yet another framework that you all are being overwhelmed with in this presentation. But what I want to actually share is a way in which that this framework in particular was deployed at the school level to support the emotional well-being of educators. So why we created Sharpen in general was to make sure that those multiple layers of influence around that child, or that purple circle at the bottom, were supported with evidence-based information and best practice toolkits. And so that, in fact, is part of what this case study that I'm going to share with you next will include. So here is our next slide, is going to just dive right into the case study for a school district in Spartanburg, South Carolina. I have worked and had the privilege of working with the leadership of this school system and with Colin Bauer, who is one of my heroes, a school social worker. They have led the charge in the upstate, especially, of doing really innovative, cool stuff. So I'm excited in many levels to share the work. In fact, we launched the Suicide Prevention Task Force that I was referencing in collaboration with this district. They just wanted to do as much upstream as they possibly could. So that bi-directional ripple effect that we've seen so much from a suicide loss, a loss in our community, it not only is going to impact, of course, the individual and their family, but everyone in the district, as you all very well know, and certainly our society. So we took that lens of suicide prevention. We took a safe and protected environment, a blanket of support for our kiddos, and we deployed it in our first phase recently. And I'm going to share some of the data, some of the strategy, and all of the examples of kind of how we utilized all of the frameworks that I've just been sharing with you to actually improve some health outcomes at the individual level. And so next slide, please. Here is Colin. He and I, as I mentioned, we met at the Suicide Prevention Task Force. He is just a hero on every level. He is also the McKinney-Vento liaison for his district. We've done a lot of innovative after school programs to improve resilience for pre-K students together. Just cannot say enough amazing things about my buddy Colin. So we work together to kind of take all these frameworks that we're talking about to actually serve up a version of Sharpen as a resource to support just educator emotional wellness and to improve mental health literacy. Next slide, please. So here you're going to see the systems approach. We're going to take these frameworks and in this short case study, cover the steps that we actually took together to create a meaningful tool that meets educators where they are, given our climate on every level, and to learn how to self-regulate for themselves in order to become more effective in the personal and professional lives within the district level. So in particular, we utilize this ecological systems theory shown here to access through data the entire community as it relates to mental health. Next slide, please. So if we use a systems theory approach to evaluate the world around Spartanburg, which is what we did, we began looking at today's topic area, the trauma-informed and the ACEs data that we have. So key points from a 2021 Spartanburg County Mental Health and Suicide Data Summer Report revealed that Spartanburg in particular had a 93% increase in self-harm calls and a high ACEs among 60% or so of the adults living within this community. So because many of the individuals were employed by the district, we knew that many of the educators were going to need their own resiliency toolkit and resources to meet the educators where they are in these times of trauma and adversity. So we cannot begin, and this is, I think, a really critical part of today's workshop. We just can't begin to help the kids, though it's all of our goals, until those tiers of support are actually trained and sort of modeling the behavior that we're hoping to impart onto the kiddos that we're serving. Next slide, please. So how are you guys doing in terms of your ACEs data? Well, you guys are doing, it's about the same as what we saw in South Carolina. So not only is this case study relevant, the case study as it relates to you in New Mexico where you're sitting, the data show almost 70% of your adults are experiencing ACEs. So I'm assuming that a lot of you have had ACEs trainings. I'm assuming, just gonna guess that, perhaps some of your educators have had ACEs training by certified ACEs trainers. If not, obviously that's a fabulous place to start. And that is in Spartanburg County, in our school systems there. They deployed back in 2015 under the leadership of Dr. Jennifer Parker, an unbelievable program to train anyone who comes in contact with youth, whether it's first responders, staff, educators, school professionals, all around ACEs. It was a 3-day, in particular, a 3-day resiliency summit that would include the ACEs literature, the sort of doom and gloom of our data and prevalence, but then the whole 3rd day would be what are resiliency builders that we can deploy in the schools immediately. So as you see, you've got the same prevalence. I'm not probably sharing anything you don't already know. But when we start looking at our families whom we're serving are coming from this kind of level of adversity, there are little things we can do to meet them where they are and to support them right now in the moment, and especially the adults that we're serving as much as the children. Next slide, please. So we took that systems theory approach. We took that to gather data. We looked at the community-wide level. And other things that we found really helpful as part of the MTSS process was to complete the district level resource mapping. I've included also resources on this in your handouts for this session. What came out of what was highlighting the areas needed, professional development, ongoing training. So we brought in national PBIS thought leaders to conduct some sessions for those MTSS supports within the district level. They are willing, able, and have a wealth of knowledge around what are practical ways that we can actually deploy PBIS frameworks within our systems tomorrow. One of the outcomes of those trainings was, let's focus on our educators first. So we did this about a year ago, and that was one of the outcomes of this PBIS thought leadership. We confirmed the serious concern of mental and emotional well-being of our educators and staff within our community, of course, using this prevalence data among ACEs. And we knew we were going to have to cut through a lot of stigma. We just know our district. You all know your district very well. So we leaned on some community public-private partnerships. We have a strong United Way in our community. It's actually under the United Way of the Piedmont in our area in South Carolina, where we have a behavioral health task force. So all of us sit together, again, more task forces. However, in our community, we actually get some work done after the outcome of these task forces. And that's thanks to these private-public partnerships. So that's another strategy for you all to consider. Next slide, please. The resource mapping that Colin did and the MTSS team leads within his district, sort of using all that data, they decided to create what we called mindfulness for educators, Mind for Ed, which is a customized version of the whole Sharpen system that provided this toolkit to focus strictly on teaching about trauma, resiliency only for educators themselves. The areas included their own stress busters, emotional literacy, mental health literacy, specifically just for them. Mind for Ed was created and then launched through several different professional development workshops that Colin held. Next slide, please. We sort of technically modified this toolkit to just meet the educators where they were. And so I'm just going to speak very openly here. Some of our communities right now, we're not allowed to talk about CRT. We're not allowed to talk about social emotional even. We're not allowed to use language. I'm just going to couch it under a broad term. Many of you may be nodding your heads saying, so we had to remove, for example, any reference to social emotional, or even the word mindfulness within the community we're serving. And I highlight that because if people who we are trying to reach and improve their health outcomes see words that are triggering, or that whether it is correct or incorrect, we are not able to help them bring down some of those barriers that we see. So to meet the educators where they were, to meet the district and the politics, frankly, around the community we were serving, we decided to just use neutral language that did not include social, did not include mindfulness, did not include words that might be triggering. We looped in those documentary style film trainings. So a lot of them are mindfulness based interventions. We called them brain breaks or emotional wellness toolkits. We added direct connection to the EAP services. And in fact, the district leadership kind of leaned into EAP for our educators, providing increased sessions and treatment visits. And I'm going to share some of the data on that, which is also very exciting. And of course, we put a lot of destigmatized content into the feed. So in terms of the demographics and socioeconomics with our culture within the Spartanburg community, we have great diversity, both economically and culturally. So we wanted to make sure that there were peer-to-peer, strength-based stories of resilience in the feed of the Sharpen system, so that when these educators logged in, they saw people who looked like them and spoke like them. And so that to me is the exciting part of the work that I've had the privilege and great privilege of doing, is building over 4,000 of those films in the course of my career. So the results of the launch, after all of this, the results of the launch were that naturally we had increased engagement with EAP. We had increased engagement. We had over, within the first month, we had over 47, we can count de-identified clicks to treatment support. Over 47 almost immediately of the 400 educators that were on the service, we were able to see a great increase in their connection to their own care. So check a box. We felt like if that was the only thing we accomplished, that was super exciting. We also increased their understanding of mental health literacy using the model and the evidence-based structure that I pointed out earlier. We certainly saw a great increase in their consuming of mindfulness and MBSR, mindfulness-based stress reduction content, so to improve their own emotional resilience and wellness. We saw an increase in emotion regulation in the workplace itself. So our great hope behind the scenes, you know, Colin and I were like, wouldn't it be cool if when we deploy this to the educators, they actually go, hey, this might be really great to show to the kiddos. And so lo and behold, that socioecological model was proving to actually be, you know, on the leg that we hoped it could stand on. Next year, we're actually going to, driven by the thought leadership at the educator level, but at the administration level as well, they're now wanting to roll out the next tier of training to go to the rest of the educators and the parents within the community. So the idea was sparked because we were able to meet the educators where they were in terms of the content and the language and the approach. So nothing can highlight, especially given these times, the importance of that more. In the future, we're also engaging in an IRB study. We have some doctoral level researchers in mindfulness, in resiliency, that are supporting this district through an IRB study to simply watch and make sure we're following best practices and meeting the health objectives that all of us seek to learn. So I want to highlight that because we brought the educators directly into the process as the sort of psych team and the MTSS team, we were able to meet them where they are, empower them, help them improve their own mental health literacy and health outcomes. And hopefully now what we're going to see is that will have a catalytic effect to the next tier, hopefully the students themselves. So stay tuned for that. Next slide, please. I've only got 4 more minutes before we want to just pause and ask for all of your ideas and suggestions, but I did want to do a little bit more of a deep dive on these 50 components putting districts at risk. I want to highlight the ones certainly that focus on suicide risk within your community. And so I'm just going to pull 1 or 2 of them in the 1 or 2 minutes that I've got left today. This itself is actually an entire training. It's a 3-hour training, the 50 things that are putting your district at risk. I want to address just a couple of the ones that I think might be relevant, but you guys are obviously the experts in that. So one of the things that I think you all should know, especially walking out of this training, did you know that there is a lag time in research? So one of the many risks that we found within districts across time was that the lag time with thought leadership coming out of the NIH or the NIMH in terms of data, evidence-based, empirically driven solutions, on average, there is a 10 to 15 year gap between when the researchers in the institutions are developing this cool primary prevention, exciting information, and when you guys in the trenches are actually getting that. Now we're doing a much better job translating that research and getting it into the community, but that was a huge pain point. So I can't stress enough, because you guys don't have the time to be diving through all the journals and the best, the research that on that level, though I'm sure all of you do. Focusing on research-driven solutions was a critical gap. And I say that because we want to be looking at recent research within 5 years, and we want to be following just the areas of research that we think are most relevant to our humans. In my world, that's child and adolescent psychiatry and psychology, the best practices around epidemiology in terms of public health and prevention. And we want to make sure that we are using the safest possible upstream measures in the district. So things that are tested, tried, and true, and looking deeply at that empirical data before you deploy that stuff in the school setting. That is my wish and my hope for all of you. What I do is, my job is to seek that information out and put it into the platform of Sharpen. So that is my goal in life, is to connect with every single prevention researcher out there and get you guys the tools and supports that you need. So that one I thought was an important one to point out. We've talked at length about suicide prevention and postvention. If you haven't been trained in postvention, we don't do any of this training in grad school, right? Not a lot of us have been trained in our social work programs, in our clinical training programs around actual suicidology. That is a national fact. And so I have combined, again, a list of outside training having nothing to do with Sharpen or Stop It, where you can access the thought leadership around suicide prevention and postvention. And I just encourage you, reach out to me, reach out to those assets that I've shared with you to get more training and support for yourself or for your district, if you don't already have those. The lack, honestly, one of the kind of a scariest thing is, so we would go into every school district, and I know I'm on my last minute here, so I have my counter counting off. One of the things we found in districts across 14 states over 20 years, and this was just true, if I were to be holding a talkback session with all of you guys, if I asked you all, do you actually know what the protocols are, whether you have a Department of Mental Health or your crisis response team, do you actually know the top 5 protocols to do tomorrow when you've got a kiddo sitting in front of you? Probably a lot of you now are going to say yes, because I think the benefit, unfortunately, of COVID is that we started leaning into these best practice protocols. You would be shocked how many other districts and how many other states, the school-based professionals, the mental health supports actually weren't aware, what am I supposed to do when I've got a kiddo in crisis? So if you are like those many individuals and you're being overwhelmed because we have such prevalence right now, don't take that on yourself. It is our job as a community to make sure that you are connected to the resources and assets that can best support you in your role, so that we are putting that life mask on you, as Matthew so eloquently said, so that you can get some oxygen and breathing room here, because I know you guys in the front lines, you're just seeing it all, and it's an unbelievable time. So I'm going to pause there, bring it back around to everyone else on the team here, and just thank you all for allowing us to be a part of your day today.
All right, and we'll open it up for questions. If anybody wants to take themselves off mute or put the questions in the chat, this is your opportunity to do so.
I have a question, and I want to also just say thank you to Robin and Matthew so much for this. It's so important. But I was wondering if there's any recommendation on training around trauma-informed education, where we're seeing tremendous behaviors from kindergartners with violence and just really having a difficult time pulling themselves together. And so it's really important how we respond to these kids with such high level of difficulty in their behaviors, to not accelerate it or exacerbate it. And so in my studies, it's always being really kind, really calm, and, soft face, where, when you get punched, you want to just yell at that child. And I hear a lot of talk around what these kids need is a good spanking. They're not being handled at home. We're having to be parents. And if you could give some recommendations on how I can better help my staff, I would really appreciate that. And thank you so much.
Absolutely. Matthew, you want to take that? I'm happy to jump in or whatever.
Yeah, Robin, why don't you jump in and I can fill in anything.
Yeah. So obviously Sharpen and Stop It together provide a lot of professional development on some of those best practices. So out of the gate, I'm going to give you some good news to get started. So over the course of 8 years, we've deployed actually a classroom-based curriculum. It's called 5-Minute Mindfulness. And I wrote it in collaboration with all of these partners in Resilient Schools initiatives. So we offer that in our collaboration with Stop It, along with some PD really for your educators and school-based professionals, whether that is digitally accessed and or live Zoom. So there's resources there that we are happy naturally to provide. I also would encourage you guys. I did have a question in the toolkit in the box here about that handout resource that I've been referencing, how they're actually getting that. So maybe some of the Sean or others on the leadership side of this workshop. Within that is a group called the PACES Network. You all know that network already. So you want to, I wrote it into the chat area, and the links are in this the magic handout document that I've been referencing that I hope y'all are getting access to. There you go, Sean, thank you. It's in the chat there. So the link to PACES network, which is really both adverse childhood, but also we're trying to look ahead at protective prevention of those adverse childhood experiences within the school systems. So join the PACES network. There's over 50,000 of us that are members, tons of training, tools, free resources. We've also got films, right? So I can't not talk about the work of my husband, who is a documentary filmmaker. We have been developing documentary style trainings on these tough topics for over 20 years. We know the right way to do it, the right way to do that in a safe and protective way. Some of the solutions that we now offer through Stop It are really like feature-length documentaries that help everybody understand the importance of compassion. Paper Tigers is not a film we made, but Paper Tigers you would find through the PACES network. It's a fabulous training resource. But really bringing in an ACEs certified trainer to meet and work with your educators to serve them and bring them, the robustness and the toolkit for their own well-being. And frankly, because they are suffering from compassion fatigue, they're tired of dealing with these kids that are, ODD and acting out sort of in the classroom setting, right? So we can back it up and bring some real thought leadership around adversity into the school system. And I'm happy to work with Matthew to coordinate that level of training for anyone on this call.
And just a quick note to add too, that training is really around, when something happens, how do we react to it, right?
Yep.
How do we control our own emotions so we can make the best decisions as administrators and staff and parents and whomever else. Another, aspect of being, we're talking about tools, is getting ahead of it, right? Not re-traumatizing a student when they walk through the doors so that this negative action happens, right? If a teacher is informed before a student walks through the door that something negative happened outside, let's say there was abuse at home, or the children's parents were being divorced, or something like that's happening at home, for example, a student walks in, a teacher doesn't know that, or a counselor doesn't know that, the littlest inconvenience can now set that child off, right? So that's when this training needs to happen. That's when the stress goes up. If we can stop that re-traumatization before they come in, having a clear communication path from home or from the student or from the student's friends into the school, right? We talked about sort of anonymous reporting, always thought to be around, I saw Michael pushing Sally, right? I saw this bullying incident, I saw this. The other thing that we're seeing through our own customers is that culture change when they're saying, hey, my friend Michael's parents got divorced. He doesn't seem like he's taking it well. Can you just keep an extra eye out? So when Michael's just gazing out the window, don't go, hey, Michael, wake up, pay attention. What are you doing? Something happened, pull him aside, have that conversation. Hopefully we can stop some of these aggressive behaviors from happening in school if we get in front of that communication as well. So just another angle that we could talk about as well.
There's a question in the chat that I want to make sure we address. Letitia, thank you for your question regarding tribal entities or rural areas, how we can be serving those family members and individuals within the community. So in general, that's a national pain point just in terms of access to resources. One of the districts we worked with in the state of South Carolina, I was on the call with an administrator who was like, can you deploy any of these trainings through a fax line? And I was like, well, we actually need, right, our access to broadband Wi-Fi and technology is critical. And so addressing individuals and family members who don't have access has been a part of what we've done at the grassroots level for over 20 years. I've got a lot of strategies for that. I don't have those included in today's handout. That's kind of a different focus area. I would be happy brainstorm or deep dive with anyone that is seeing kind of more rural, lack of access to Wi-Fi technology, things like that, because we have some strategies that we've seen effective, including, sort of bridging that digital divide, that I would love to brainstorm more with you, Letitia, or anyone else. And obviously you could go through Matthew to contact me.
Awesome. Thank you so much for that.
You're
And
welcome.
also, just to add to that as well, the grant that we currently have services any public or private K through 12 school district. So tribal or public, it's the funding's there and available for you. So we can definitely have those conversations. And we've worked to service grants up in Alaska, North Dakota, other rural tribal-based states as well. So fairly experienced, not as experienced as you all folks on the ground there, but fairly experienced with that through funding initiatives, working with a technology solution in some of those areas that don't have Wi-Fi. We have other workarounds and so on, so that the students and the staff members, when needed, can get help.
I love the question, why aren't administrators required to attend trainings? And I know we're recording this, and I know there's politics in everything we do here in the world of Sharpen and Stop It, and these fabulous opportunities to learn and grow. I've found it helpful, and through district-wide, again, some of these public-private partnerships where we're using data to drive decisions and programming that go into districts, best practices across the literature in school-based mental health. If you look at the research of Mark Wiest, the work that he launched in the school-based mental health best practices out at Maryland, right at the School of Medicine in Maryland, that Office of School Mental Health. If you look at the data and the research at PBIS, Positive Behavior Intervention and Support, you look at the research and data, it's always, we've got to bring the administrators to the table to be trained. They have got to be a part. And from my perspective and what we've seen successful in our communities and in some of these case studies, using data to get them there is often helpful. How successful, we couldn't be successful, frankly, at all without the administrators being open and compassionate to servicing the youth and the families that all of us are so passionate about serving. So if you need more of that data, if you need for me to help you, point you in that direction, I would be happy to do so, and give you some of the other case studies we've used in other school-based deployment to help get some of those administrators to the table.
Robin, while folks are thinking of other questions, and if you have other questions, please jump in. Now that Sean shared the handout that you have with all of the links, would you mind just taking 2 minutes and going through that and maybe highlighting where folks start? I know I just opened it and it was just an overwhelming amount of information, but maybe just giving the folks on the call I would check out maybe 1 or 2 of these things first. This is a great place to start.
So the first top third of that, just to check a box so you guys can see who we are, what we do, my research, and we just are very transparent about that, because I know you're all very intent in making sure you can look under the hood, as it were. So we've published a lot of information that I spoke about today in great detail. The resource mapping, that top link, that's the National Center for School Mental Health that I was just talking about. So when you're looking at following best practices for getting ahead of prevention or intervention in terms of mental health, please follow University of Maryland. Dr. Mark Wiest is the founder of that institution. He's now based in South Carolina. But the National Center for School Mental Health is a fabulous resource for you, not only on resource mapping, but other assets. And I've mentioned Dr. Caridi, the suicide prevention resources there. So a ton of free tools and resources available to your district. Looking at the other highlight is down at the bottom on the top first page. There is a link there to we call it SPRC, the Suicide Prevention Resource Center. There's always a little cohort in each state. So your link there, the Suicide Prevention Resource Center for New Mexico, I've included there, and all of your different crisis lines. And you guys kind of have crisis line overwhelm like we do in the state of South Carolina. One thing I found helpful, Matthew, and this may be where you also might want to speak to this just regarding Stop It. So because we are at like crisis line overwhelm in our states, every crisis line, at least in my experience, kind of has a different purpose. So I actually brought in all of the leaders of each of the different state crisis lines to my task force meetings for my suicide prevention. And I actually asked them to go through specific use cases. Like, I've got a 12-year-old kiddo sitting in front of me who's actively planning, who has a plan for suicide. Which of these 27 crisis lines am I supposed to call, and exactly what happens? And so, Matthew, I know that's a part of the service. I don't know if you want to jump in there with some of the resources that you guys might provide in that moment.
I actually need to pause you right here.
Yeah.
We need to do a final attendance poll for everyone here. So I know that there's a lot of resources. So thank you very, very much for that. We're going to do a sign out poll. So that way people who are doing continuing education can get their credits. Thank you, Robin. Thank you, Matthew, very much for your informative, excellent presentation. I know that they, did you provide your email addresses in those documents as well?
Yep.
Yes.
All right, wonderful. I definitely, if you have further questions or if you would like to reach out to either one of the presenters, they are in those documents as well. So thank you very much. And everyone who had taken part in that discussion, the Q&A portion, and your generous support for the school health community. I appreciate that very much. We're doing that attendance poll right now. So don't forget to complete the evaluation that is going to be using the link that we're going to be posting in the chat. This link will also be emailed to you after this. So remember, completing the attendance polls and evaluations are requirements to receive continuing education credit or certificate of attendance. It's very important. So definitely make sure to take care of that. I'm going to also thank everyone who attended. And please like our Head to Toe Facebook page for announcements on upcoming sessions. We'll make sure that if you have an opportunity, just search for Head to Toe 365 for Facebook. And I want to thank everybody again for attending today's session. And I hope everyone has a great day. Matthew, if you have any closing remarks for the last 3 minutes here, go ahead and have at it.
Well, thank you, Sean, and thank you for everybody attending, and Robin for being a co-presenter with me. Again, I know, we've dropped a lot of statistics, a lot of facts, a lot of frameworks and everything. Please review the resource documents that Sean put into the chat. I believe they'll be hosted up on the Head to Toe website as well. So please, most importantly, there's a lot of information here. Don't try to go back and start everything, or, hey, we just learned all these great frameworks, let's dive into everything. Start with one. If you have questions, please reach out to myself. I can get in touch with Robin if needed there. And again, there's plenty of funding and opportunity and sources out there. Stop It is very good at finding funding sources. We do currently service a federal grant around mental health and school safety in the state of New Mexico. So please, if there's any way that either of us can be resources for you, don't hesitate to reach out. And if we don't know, we can definitely point you in a direction to find out or to get some help as well. So again, just thank you very much for your time today. Robin, I don't know if you wanted to add anything as well.
I think just grateful to you all for your time and for sharing space today, and just a word to all of you to please take care of yourselves. I know what it's like out there, and I know at least what it's been like in the state of South Carolina. So my heart goes out to all of you. I know there's just a lot happening, and make sure you employ that self-care for yourselves.